This is all stuff that most of you should know, but we've got a lot of information to cover, and so hold on, and I'll try and get through this as painlessly as possible. So brain tumors, as everybody knows, is the second commonest group of cancers in children after the leukemias. As a group, obviously covering a lot of different histologies, it's the most common group of solid neoplasms. Right now, 2017, the estimate for cases in the United States in 0 to 14-year-olds is about 5,000 cases of brain tumors. And for a level of precision unjustified, about 74% 5-year survival rate if you take everybody 0 to 19 years of age. So this is the 5-year survival rate data through the SEER registry through 2009. And the point to be made here is that if you're going to get a brain tumor, do it when you're young, because if you get to be in any of these intermediate ages, and tragically, I've now gone into this block right here, so I'm in big trouble. So it's clearly an issue of doing it when you're young. Sorry. And why is that? Why is it that kids do so much better with brain tumors if they're diagnosed, as a child versus an adult? And this is information that comes from the Central Brain Tumor Registry of the United States, but it makes the point that what children see in terms of their brain tumors is a very different spectrum of diagnoses than what adults see, and that's really pointed out by the fact that, with the exception of embryonal tumors in the 0 to 4-year-old children, polycystic astrocytomas predominate as the most common brain tumor seen in children through teenage years, and then second most common, even 15 to 19. In adults, with the exception of meningiomas, and particularly after 45, glioblastoma predominates. So remember that we're not so much better at treating kids, they just have a very different group of diseases than what we see in adults. Okay, so this gets into the stuff that makes everybody completely crazy, including, it seems, the neuropathologists, actually, who constantly are changing how they're going to describe brain tumors. So there's a lot of different ways to think about brain tumors, but there's a few things that I think can make it a little simpler so you don't get completely befuddled. If you think about the brain in terms of the cells that exist in the brain, there are really 3 types of cells that exist. You have cells that are glial, and they come in a lot of different flavors: astrocytes, oligodendrocytes, ependyma cells, choroid plexus. You have neurons, which we'll call the embryonal cells. And then you have what I'll call other stuff, which are primarily microglia. And I call it other stuff here for your purposes because the tumor that we think arises from microglia are primary CNS lymphomas, and that's not a pediatric diagnosis. And so all of the business of your patients that you might see are going to be patients who have tumors that are glial in origin, neuronal in origin, or some mixture of the two. Now, in the former WHO classification, and in fact, up until this year's talk, I would have told you this. I would have said that the WHO defines 7 categories that really cover all brain and spinal cord tumors, and the ones in all capital letters are the ones that you need to know about in the pediatric setting. So tumors of neuroepithelial tissue, germ cell tumors, tumors of the cellular region, which is primarily craniopharyngiomas, which I shouldn't be talking about because it's not on the boards. But that's how they sort of set it up before. And then I would drill down and tell you, okay, here are the tumors that are of neuroepithelial origin. And you'd look and you say, well, isn't that everything? And in fact, it's basically everything, right? So astrocytic tumors, oligodendral tumors, choroid plexus tumors, the mixed tumors, embryonal tumors, all fall under sort of tumors of neuroepithelial tissue. But the WHO kind of screwed me this year because I thought this was the last time I was going to do this talk, and I was like, I'll do it again because I have to recert and I can get the free book. And I thought I just have to modify a couple of slides and then curse the WHO if they didn't completely change the brain tumor classification in 2016. And so it's a completely different classification schema, and so I'm not really quite sure where this will play out in terms of the boards. All the tumors are still sort of the same, but they've just kind of been sort of modified in terms of where they sit within the nomenclature. So what I've done here is I've told you what I believe amongst the many categories that are now defined by the WHO, what I think the relevant pediatric categories are amongst those many categories. And I've listed them there. And then what I go on to do, and I want everybody to get ready because you know that rumbling noise you make when you turn your book to like the next section? Well, we're going to skip a whole bunch of slides in just a sec here. so get ready because it's going to be really loud. But what I've done then is I've taken each of the categories, for example, diffuse astrocytic or oligodendral tumors, and I've then identified what the particular subtypes are that sort of fall into that category, and tried to give you the ones by pulling out things that are really largely adult or not seen in pediatrics particularly often. So for example, for the diffuse astrocytic tumors, diffuse astrocytoma, which is the WHO tool, we'll talk more about that in a sec, anaplastic astrocytoma, GBM. The diffuse midline glioma, which is the H3K27M mutant, we're going to talk more about, but this is now the pathologic description of what you think of when you think of DIPG, and we'll talk about pontine gliomas in a bit. I do want to make one point about nomenclature that confuses people sometimes, which is this low-grade versus high-grade glioma business. So we, in the trade, those of us who've chosen to do brain tumors, will use the term glioma in a very kind of generic way. When people say glioma in children, that's synonymous for your purposes with astrocytoma. If I were talking to my adult neuro-oncology colleague and said, I have a patient with a low-grade glioma, the first question they would ask me, astrocytoma or oligodendroglioma? In pediatrics, it's almost all astrocytoma. So low-grade glioma, high-grade glioma, for the most part, really means astrocytoma. As you know, astrocytomas, as an example, come in two major flavors. Pilocytic astrocytomas, which in the World Health Organization are considered a grade 1 tumor, and then the diffuse astrocytomas, which include the low-grade WHO2 and then the higher-grade anaplastic astrocytoma and GBM. High-grade versus low-grade is just a cutoff based on the WHO grading between grade 2 and grade 3. So that's important to know. Okay, get ready, we're skipping. So you're on slide 10. We're now going to go to slide 16. So all of these other ones are just the categories that I've shown already, where I've simply identified the subtypes within each of those tumor types. So it's a good reference for you, but I don't need to specifically speak on that. I do want to say one word about the ever-burgeoning category of medulloblastoma, and we'll talk more about this a little later. But what the WHO has to do, of course, is has a classification that works for the world, because that's why it's called the WHO. And so for that reason, they've had to, when there are specific molecular diagnostics that they believe are important, have both the molecular or genetically defined group and the histologically defined group. And medullo is perhaps the worst example of that, where there is now an entire grouping based on what are the genetically defined subgroups, and then in the absence of being able to do that testing, the histologically defined subgroups, which really, again, are based on morphology. So that's, again, important to know, and we'll talk more about that in a sec, but I just wanted to pause there. We are now moving on to slide 21. Now, let me just say one other word about the classification. The most important thing that changed in the WHO classification from your perspective is there is no such thing anymore as a CNS PNET. PNET no longer exists in the classification, which is kind of shocking to people who spent their careers thinking about that. There are ways it's been renamed. I'll talk more about that as we move forward, but there is no such thing as supratentorial PNET in the new classification. So we have to talk a little bit about neuroanatomy, and you'll be pleased to know you only have to know a teeny little bit about neuroanatomy. You do need to know how to write MRI requisitions, but neuroanatomy, not so much. But there's a couple of things you have to know, and the main and probably the most important thing is that the brain is divided into two big compartments. So you have the supratentorial compartment and the infratentorial compartment. And as you're aware, the infratentorial compartment really encompasses the cerebellum, the brainstem, the region of the fourth ventricle. The supratentorial compartment is all above it. And the anatomic distinction between those two areas is important because the tumors that occur in those areas are quite different. So what I now go on to do is identify those three areas plus those two areas plus the sella as sort of the third area. And in a series of slides that will follow, which I will walk you through, I'll give you a little bit about sort of what tumors tend to present in those areas. So again, it's another way for you to look at this, which is I see a kid with a tumor in the cerebellum. What things should I be thinking about that at least live in the posterior fossa? Even though you spent a lot of money for this course, they still won't do the book in color. I don't know why they won't do the book in color. It must cost a lot of money. But so it's color on my slides. Sorry that it's black and white, I believe, in the book. So if you start with tumors of the posterior fossa, again, there's a certain number of things you're going to need to know. And the questions on the board always sort of play this game of, a kid presents with something in their cerebellum, and then you have to sort of know what that differential would look like. So I've listed again here all the tumors that occur in the posterior fossa. So in the cerebellum, pilocytic astrocytomas, medulla, ependymoma, and ATRTs. In the brainstem, the tumor that you need to be aware of course, is DIPG, which I've explained to you now under the new classification is really defined by this particular histone mutant. You can play this game in each location in the brain. So in the sella, there's a variety of tumors that occur, craniopharyngiomas, a bunch of benign lesions, pilocytic astrocytomas, germ cell tumors, which are exceedingly more common than LCH, despite what Carl said this morning. In the thalamus, which, by the way, in your book isn't look like it's over the thalamus, so somehow the little circle got moved, but just make the circle match that place where I have it in the book now. That's your thalamus. There you have, again, a number of tumors. And this is kind of the first place where what you used to call PNET sort of shows up on the listing. And those are CNS embryonal tumors and variants. So that's how they're described now within the WHO. I think PNET will still live on your tests because I think that the board isn't quite that facile in terms of moving to new nomenclature. But be aware of the fact that this will now be some CNS embryonal tumor or a variant. Pineal region, the two big tumors there to think about really are pineoblastoma and germ cell tumors, and again, we'll talk a bit more about those in a sec. And in the hemispheres, you can kind of get anything you want, really, but low-grade and high-grade gliomas, the things will, like the actor or the singer formerly known as Prince, we'll call it, PNET, ATRTs, ependymal tumors, and then choroid plexus tumors. And then just to say tumors of the optic pathway, which really for your purposes, optic pathway gliomas, generally speaking, are pilocytic astrocytomas and retinoblastoma just got there for fun. Okay, so they do ask you to know how do tumors present, which is kind of funny because none of you will actually make the diagnosis of a brain tumor. It'll come from somebody else and then get sent to you, but nevertheless, you should be aware of this. One of the things you have to have some understanding of is the distribution of tumors by anatomic site. And so this is a little pie chart that I made, which sort of shows that information. What you can see, though, if you look a little bit, is that the cerebellum up here in this kind of mustard color, I think every time you do this, you have a high risk of advancing the slides. Is a good chunk of the pie in kids. The brainstem is a good chunk of the pie in kids. Other brain covers a little bit of the infratemporal compartment. Ventricles can be anything, but often includes the fourth ventricle where ependymoma shows up. So a lot of tumors in pediatrics live in the infratemporal compartment, and you need to be aware of that. But particularly the younger you are, the more common that is. And that will have some impact on how tumors present. So the first are general and non-localizing symptoms, and as the name suggests, they're general and non-localizing. So things that everybody sees all the time. When I give this talk to general pediatricians, or the residents, they all go like, oh my God, how many kids did I send home with a brain tumor who came in with a stomach ache? And the fact is, this is a tough group, right, because they have symptoms that are very difficult to necessarily point you to a brain tumor at diagnosis. You can read this story. This was a patient that came to my attention who was a teenager who was having a lot of neuropsychiatric symptoms and all these kind of things going on. And I think really just to appease the mother, eventually someone went and got an MRI. And lo and behold, they have this little small, non-contrast enhancing little T2 bright lesion kind of in the thalamus there. And of course the mother is like, I told you, you dumb doctors, that my kid had a reason. And I said, I got good news and bad news. Your child has a brain tumor. They're still crazy, but they have a brain tumor. And most of the causes of the brain tumor, most of the symptoms have nothing to do with the brain tumor in this sort of incidental finding. I have excellent bedside manner, in case you're wondering. The group over at Hopkins can tell you, seriously. increase intracranial pressure is what everybody sort of thinks about. They figure, like, here's the deal. You got a brain, you got only so much room at the end. If you block CSF outflow, you'll have something ballooning and causing pressure, or some masses simply by the sheer bulk of the mass can cause raised intracranial pressure. As everybody knows, the dyad of raised intracranial pressure is headache and vomiting. The problem, of course, is that headache and vomiting occurs in lots of other symptoms. Irritability, I would argue, in vomiting is sort of the headache of infancy, so a really fussy 1-year-old who's having intermittent, sort of unclear vomiting might be that problem. If you have a fontanella, it can bulge. If you have sutures and that can separate still, they can do that. Papilledema is the most important symptom and the most common thing that is seen in terms of what you'll see for raised intracranial pressure. There are things like Perrinode syndrome, which has a variety of things. What everybody learns about is that you say look up, and they can't look above the midline, and that's sort of pressure in the midbrain, usually from tumors in the pineal region. And then there are other symptoms that are not sort of directly ICP, but they're probably really transmitted pressure to normal structures. So you obstruct at the level of the fourth ventricle, and suddenly you have more ataxia as a consequence of that. Here is an MRI that shows evidence of raised intracranial pressure. So you can see this mass here in the region of the midbrain. And then you see this here. In this slide, I really should update it. We used to call it transependymal CSF flow. So the idea was the balloon blew up. There was no place for the CSF to go. The design of the brain was bad, and it didn't stop making CSF when there was no place for it to go. And so it would push CSF out into the parenchyma adjacent to the ventricle. It's probably a little bit more appropriately described as periventricular interstitial edema. So there's pressure, and then there's this normal sort of fluid interface there, and fluid can't get back in as it gets out and that sort of stuff. But the point of it is you see this sort of finding. That's the real sort of key that there's pressure. Because the alternative explanation for why you have big ventricles is you have a small brain. And small brain, so if you're hydrocephalus ex vacuo, you wouldn't necessarily see any kind of transependymal CSF findings. And then the third is localizing signs, and obviously what you get depends on where the tumor shows up. And so what I've done here is I've tried to take different parts of the brain and tell you what those common signs and symptoms are. Remember, just to sort of reinforce this, that many of the tumors in children, particularly out of infancy, okay, so if you get out of the hopper without a brain tumor and you're doing okay, and you're not born with a brain tumor, then you're unlikely to have a supratentorial mass early on. So children that are born with congenital brain tumors have a higher incidence of some supratentorial masses. If you develop a brain tumor at year 1 or beyond, for a long time, it's more likely to be infratentorial. So think hard about infratentorial symptoms when you're thinking about kids presenting. And a 4-year-old who presents with supratentorial symptoms can have a brain tumor, but it's actually quite uncommon. So for example, seizures as a presenting symptom in children with brain tumors is actually fairly uncommon because most tumors occur in the infratentorial compartment, and you don't seize from tumors typically in the infratentorial compartment, at least without some other associated symptoms. So I've given you a listing of the kind of things to look for, but think infratentorial, think about the cerebellum, ataxia, those sorts of things. Think about the brainstem, so cranial nerve findings, some autonomic function, obviously long track signs because everything's got to get through the brainstem to get down to the cord. And here's an example of a kid who might have localizing signs. So this is an MRI of a child with a diffuse pontine glioma. And this kid will probably be a 6 or 7-year-old who presents with maybe a 6th nerve palsy or a 7th, maybe a little bit of weakness, maybe a little bit of ataxia, and obviously pretty much the worst diagnosis in all of pediatric cancer, no matter what the sarcoma docs say. This is another example of localizing, oh, sorry. This is painful. This is another example of a localizing sign. So this is a child with an optic pathway tumor. We would call this an optic pathway glioma. You should call it a pilocytic astrocytoma of the optic nerve. But their localizing sign will be proptosis. Now, there's some questions about trying to understand the imaging features of brain tumors, and this is like the dumbest question that is in the board content because it's extremely difficult to sort of tell you this is the classic imaging of any particular tumor type. I've made some effort to try and give you at least a little chart that you can use that might provide you with some guidance about what you might be looking at. But as you can see, it's pretty difficult. So if you take, for example, what I've done, I've listed some of the tumor types. I've told you where they can occur. So medulla obviously is a cerebellar tumor. If it's young, it tends to be in the midline. If it's older, they tend to become more lateral. I've told you whether they do or do not take up contrast. Again, these are the typical cases, but there are many exceptions. I told you if they're bright or not on T2 or FLAIR. Most of the tumors are. And then I've given you a few specific notes about some of the tumors. It's really hard. I've tried to put in some images for you for each of the tumor types, but it's difficult, I think, to try and give you really clear things that if it looks like this, it must be that. Because I can show you medullos that don't enhance. I can show you low-grade tumors that aren't pilocytics that do enhance. And so it's a little tricky in terms of trying to give you specific information on imaging. Okay, so how do we treat the tumors? And we haven't come very far. I'm actually pretty sure that this is the same slide that I used the first time I gave this talk in 2002. Maybe I've upgraded it a little bit. So there's really three things, as you know, we can do when we treat patients. We can cut it out, we can fry it, or we can poison it, right? And this is a listing really trying to tell you what are the things that we do, and what do we do all the time, what are the things we might do, and what are the things that you might arguably say are still not proven and hence really should be done more in the context of clinical trial. So surgery, for example, is really used for diagnostic purposes for almost all tumors. There's a couple of exceptions. Radiation therapy can be used for almost all tumors. Again, we'll talk a little bit more about that. And chemotherapy, which has sort of been the latecomer to the show, I think is widely utilized in certain tumors. It is increasingly utilized in other tumors. And in some cases, there's very little evidence of its utility, maybe should be only done in the context of clinical trials. So why do we need the neurosurgeons? That's actually a question I ask myself frequently. You need it to make a diagnosis for most of the tumors. There are a couple of exceptions. So diffuse pontine glioma, if it's classical imaging, you can make that diagnosis by MRI alone. And then most non-germinoma germ cell tumors, we'll talk more about that. So these are secreting germ cell tumors. They will typically have elevated tumor markers either in serum or in CSF or in both. And you may be able to make a diagnosis without any neurosurgical intervention. What I want the surgeon to do is to cut the whole thing out. I cure more kids of their brain tumors if they actually don't have a brain tumor anymore than the kids who still have a brain tumor. So that's what you want, but as you know, the brain is the brain, and there's things you can't do in the brain, and so debulking or a biopsy may be all that's possible. They do other stuff like supportive measures like shunts and omiyas. Radiation therapy is superb therapy for brain tumors. If you could give radiation therapy with impunity, you would cure every single kid with a brain tumor. As you all know, you can't give it with impunity. We can use it in most cases. There are a few tumor types that we try really hard not to use it in. Choroid plexus papillomas, which we don't really talk much about, they're surgically cured and you shouldn't have to do it. And the low-grade gliomas, again, low-grade astrocytomas, grade 1 and grade 2, these days I would say radiation therapy, we really try hard to defer it if not to give it at all. Full dose treatment radiation therapy depends a little bit on the tumor type, but in general 54 to 59.4 gray is the dosing. And the thing with full dose treatment is remember what you're radiating. You're either radiating the hole that we just made, so you had medulla, we resected it, and now you got a hole, and we're radiating the hole in the margin. So you can get away with that, or it's a solid mass, and you're basically doing the same thing, radiating the solid mass with a little bit of a rim. The troubling part of treatment for many of these kids is craniospinal irradiation. So there are some tumors that really do benefit from the application of craniospinal irradiation. If you give 36 gray, which is about the maximum dose of craniospinal irradiation, to a child who is less than 5 years of age, you will guarantee that child special education. You will guarantee that they will not live independently as an adult. You will guarantee they will have a menial job and will probably be socially isolated from their peers. So it's a big deal, and one of the real struggles in brain tumor care is sort of what price cure. And we'll talk about what we try and do to kind of get around that issue of radiating the youngest brains. And then chemotherapy is used generally as adjuvant therapy, in a few cases as neoadjuvant therapy. There are certain tumor types, germ cell tumors and the embryonal tumors, that it's extremely effective in. We're learning about its role, particularly as we're developing more targeted therapeutics in a variety of other tumors. There's a lot of debate about whether the blood-brain barrier is a relevant barrier to the delivery of chemotherapeutics. For some tumors, probably not. For other tumors, particularly some of the non-contrast enhancing tumors, it may be more relevant. We give a lot of chemotherapy in the youngest kids, and we do that because we're trying not to radiate them. Make no mistake, there has never been evidence that that is therapeutic equivalence. So not radiating a 1-year-old is good because if they survive their disease, they would be very impacted. But they do not have the same chance of surviving their disease with chemotherapy alone as you do when you get combination therapy. We do have strategies to bypass the blood-brain barrier, although in general I would put them in the category primarily of these days of still being relatively experimental. Okay, now we're going to go on and talk about each of the tumors, and I'm going to try and do it by thinking a little bit about the location. So these will align to a certain extent with those color pictures that are in color in your book that I showed a little earlier. So what I've done is given you a little vignette of how a child might present, or in this case a young adult, and I've highlighted in bold some of the signs or symptoms that you should be thinking about. So this is an 18-year-old male, had some headaches, nausea, vomiting, some double vision, and I guess unsteady gait got unhighlighted. But this is a really, really typical story for a posterior fossa mass. So this is obstruction at the level of the fourth ventricle. So they get obstructive hydrocephalus, and so they have raised intracranial pressure that causes nausea, vomiting, and headaches. They get some push on the brainstem with some double vision, and then often the tumor is arising from the cerebellum or pushing on the cerebellum, and that provides the unsteady gait. So again, to remind you, there are 4 tumors that you have to be aware of that occur by the posterior fossa here. I call that the cerebellum. You can scratch it out if you want to think of it that way. So medulloblastoma, by definition, a cerebellar tumor. This is the most common location for ependymoma, although it can occur anywhere in the brain, as we'll talk about shortly. Cerebellar astrocytoma commonly occurs. Most of the time, these are pilocytic astrocytomas. And then ATRT, rhabdoid tumors, you have to be aware of. These historically were somewhat misdiagnosed. Nowadays, they're not. And they actually represent a reasonable number of cases in the posterior fossa. So let's talk about medulloblastoma. And for each of the tumors, just so you'll know, I've tried to organize these more or less the same way, which is what are their clinical presentations, do they have metastatic potential, et cetera, et cetera. For medulloblastoma, as I said, most of the time these kids will present with obstructive hydrocephalus, not all the time, but common. So they're going to have raised intracranial pressure, ataxia, and then some brainstem findings are not uncommon, either because of direct invasion of the tumor into the brainstem, or often just because of push against the brainstem. This is a tumor that has metastatic potential, and so as you know, we stage the neuraxis for all these kids. So these are kids who get a spinal MRI and an LP. This is a small round blue cell tumor. It can metastasize systemically. It is so uncommon that we do not consider it a necessary part of staging unless you have a specific symptom that would warrant that evaluation. So here's the staging, as I said, MRI of the brain and spine, CSF cytopathology, and then bone marrows, bone scans, rarely, and I haven't probably had to do one in 10 or 12 years. There are some histologic variants that are important to know a little something about, which align to some extent with the genetic variants, which I believe you'll have to know something about. So there are sort of these types, one of which is this desmoplastic type of medullo. There's another sort of large cell anaplastic variant, and these variants actually do impact prognosis, so you need to be aware of them. Now, how do we risk classify medulloblastoma? So it's embarrassing to say, but yet true, that in 2017 we stage and risk classify medulloblastoma patients the same way we did it when I finished my fellowship, which was some time ago. These are the things, basically. So it's sort of a surgical quasi, do you have metastasis staging? So you are considered standard risk if you have a good surgical resection left with either no evident disease or a small amount of residual tumor, and you do not have metastatic disease. That makes you standard risk. You are considered high risk if you have greater than 1.5 cubic centimeters of residual tumor, or you have metastatic or multifocal disease. And the one exception is that if you have standard risk features, but your tumor is this large cell anaplastic variant, even if you don't have metastases, even if you have a good resection, you're still considered to be high risk. Now, here's the newer information, and I think most of you, if you have any exposure to this area at all, have come to learn that we're finally catching up in the brain tumor world, and there is a lot more genetic information about these tumors than we had in the past. I believe you will have to know something about the medulloblastoma genetics for the boards at this point. There are 4 subgroups, depending on kind of who you want to look at, but the consensus thinking right now is we think about them largely as 4 subgroups of medulloblastoma. There's a Wnt variant, a hedgehog variant, and what's called group 3 and group 4 because we don't fully understand kind of what all of the drivers are for those particular variants. What I've done in this particular chart is I've tried to tell you when it's most common to see that particular variant. In parentheses, maybe another age group that also sees it, but maybe not quite as common. So for example, for sonic hedgehog patients, infants, we see a lot of sonic hedgehog mutated tumors, not so common throughout childhood, and then again, there's another peak in adults. I've gone on to tell you something about the histology, and I want to make a point here, which is if you look, all of the histologies can show up in all of the subtypes. So while there are certain histologies that are pretty specific to a subtype, for example, nodular desmoplastic is really pretty much linked with hedgehog. Everything else, classic medulloblastoma, large cell anaplastic medulloblastoma, they can show up in all the histologies. I go on to tell you what the specific genetics are that are understood about each of those subtypes, and then something about prognosis. And what I'll tell you about prognosis and what you should know is that Wnt is a great, if you're going to get medulloblastoma, get a Wnt tumor. Not very common, about 10-15% of cases, but they have a great outlook, almost a guarantee of 100% survival with current standard therapy. The other groups, it's a little bit more variable. One thing that's coming along is the hedgehog group, the desmoplastic group, which some people have thought of as a better group. If you happen to have that mutation and you have a P53 mutant tumor, so a hedgehog mutated, P53 mutated tumor, those kids do horribly, and they may in fact be the very worst group of medulloblastoma patients. So here's typical imaging for a medullo patient. So often midline, on your boards I guarantee you will be midline medullo, M and M, and you'll need to know that. The arrows are trying to show you some areas of leptomeningeal dissemination, but it is typically a midline tumor in young kids, and as I said, as you get older and move towards younger, teenagers and young adults, it will tend to lateralize. What is the treatment for medulloblastoma? For standard risk therapy, I would say that the current treatment is as follows. If you get a good resection, non-anaplastic, you get craniospinal irradiation to a dose of 23.4 centigray. You get a posterior fossa boost, so in the area where the tumor was, up to about 54 gray. And usually most people give vincristine, unless you're me, because I think it doesn't work. And then you get adjuvant chemotherapy, and this is the typical thing, and this really follows the most recent COG study, but I think this is kind of what gets done these days, which is combination therapy with the same 3 or 4 drugs that we use in brain tumors for every single brain tumor because we haven't been smart enough to figure out anything else. But it's an AAB cycle, typically for 9 cycles. This is standard risk therapy. If you have paid attention, there was a study where the most recent COG study, for some kids, they went down to 18 gray of cranial spinal irradiation. And in that study, as a group, that group did less well than the 23.4 gray. Now, we don't know about the subsets yet, but right now, standard of care is 23.4. For high-risk patients, there is less uniformity in terms of what the treatment should be. Cut out the tumor as best you can. We give full cranial spinal irradiation, so that's typically 36 gray, same boost to the posterior fossa. adjuvant chemotherapy, and that varies a little bit. So in the most recent COG study, it's these three agents, again, at higher doses with a bit more dose intensity. But there's a lot more variation in the medulloblastoma world in terms of what the adjuvant therapy should look like. The prognosis, all-comer standard risk is about 80 to 85% event-free survival. For high-risk patients, and again, this is a huge splay because there's some really big differences in what makes you high risk. And I think that very soon we will be going to more sort of genetically stratified groupings and stuff. And if you're, for example, a hedgehog mutated, P53 mutated patient, you may be at the 20% range, and if you're some other groups, even though high risk, you may be closer to 70%. So amongst the other embryonal tumors, so medullo is sort of the classic embryonal tumor, we have all the other ones, which up until this point, again, would be called PNET and pineoblastoma. But I think you can sort of think of it that way as just CNS embryonal tumors and pineoblastoma. Pineoblastoma, remember, because it occurs at the level of the midbrain and in that region, often presents with Paranode syndrome. How a CNS embryonal tumor, aka PNET, would present is very much location dependent. We stage them the same way, although it is not clear that the risk of dissemination is the same across all of these variants. We manage them the same way, which just tells you how unclever we are, because we haven't been able to figure out kind of what the differences are and how we might be able to exploit those differences. In general, the outcome is less good for these patients. So turns out that if you look at the group, pineoblastoma patients do worse than medulloblastoma patients. CNS, everything else embryonal, does worse than pineoblastoma patients. The treatment is similar to what we do for high-risk medullo, as I've already said. And I think one of the things to be aware of is that what we learned about in the PNET sort of evaluation and why it doesn't exist anymore is that we called a lot of things PNET. And that really was, we don't know what the hell it is, but it's high grade and it's in the brain and it got called PNET. And what we're going to have to sort of tease out now is that what were we actually really treating? In the big analysis of PNETs, for example, that was done at the molecular level, about 40% really actually molecularly were high-grade gliomas that were just misclassified. A couple of embryonal tumor pointers. As I said, these are tumors that like to disseminate. You need to do an LP and an MRI for staging. I'll remind you that if the spine is done before surgery, that's great, because you can at least have the spine MRI done. You can't typically do LPs before surgery because these kids often are obstructed, and that would be a dangerous and foolhardy thing to do. If you want to do an LP, you need to wait about 10 days after the surgery to ensure that you don't have cellular debris confusing your interpretation. As I said, this is a small round blue cell tumor. It can metastasize. It rarely does. And I will say that in the recurrence setting for most of these patients with embryonal tumors, medullo in particular, if you relapse after modern medullo therapy, the salvage rate is pretty poor. In fact, it's not clear that we salvage almost any of those children anymore. Okay, on to ependymoma as another tumor of the posterior fossa primarily. It can occur anywhere in the CNS. It is very, what symptoms you have obviously is dependent on location. Often it will occur arising from the floor of the fourth ventricle. You'll hear that term a lot. And if it does, it will tend to obstruct at that level and give you raised intracranial pressure and associated ataxia. It does have metastatic potential, typically just to the neuraxis, and we'll talk about that in a sec. So how do you stage these patients? So we stage them with an MRI of the brain and spine, and we do CSF cytopathology if you're being, sort of dotting your I's and crossing your T's. From a histology perspective, there is a staging, a grade for ependymoma. So the typical sort of bland classic ependymoma is considered a grade 2 tumor. There is an anaplastic variant that is grade 3. It is very hard to tease out from all of the current work that we've done whether that makes any difference in terms of prognosis. Some studies say yes, some studies say no. Some studies it really may be a consequence of the aggressiveness of the surgeon. Genetics is tricky, and I will say I put this in. I don't actually think this is going to be on the boards. I think it's not quite there yet, but it is important to know because what you will see in the new WHO classification includes a little bit of this information. So in the posterior fossa, there are really two variants of ependymoma that occur, this ependymoma A and this ependymoma B. And the long and the short of it is to know is that in each of the locations, there's a good one and there's a bad one for the posterior fossa in the supratentorial compartment. Ependymoma A patients are typically young. They have some specific phenotypic abnormalities. Their outcome is poor. Ependymoma B patients have a good outcome. They're typically older. There's even some data suggesting you don't even need to radiate the ependymoma B patients. Don't do that yet, but it may be coming. In the supratentorial compartment, there again is a good and a bad variant. I point this out because the REL-A fusion, which is listed there, is in fact part of the new WHO classification. So your pathologist will tell you in a supratentorial tumor, this is a tumor that is REL-A positive or not. And those patients do less well. In the spine, remember that the tumor that we have to think specially about in the spine are myxopapillary ependymomas. These are tumors that are grade 1 tumors. They actually have a pretty good prognosis and often can be treated with a good surgical resection, and then we fight about whether it needs to be radiated or not. So here's a classic example of a posterior fossa ependymoma. So you see this on this post-contrast sagittal T1. You see this mass here that's kind of filling in the region of the fourth ventricle. How do we treat these patients? So aggressive upfront resection, and this is the tumor that to this day, and I think still people feel that a gross total resection is required. Now, there's some argument about that, but I would say that this is a tumor that our surgeons are very keyed into the idea that a good resection is very, very important. And some of these kids, if they go in, get a resection, it's partially resected, and they come out of surgery and we see the scans, we'll ask the surgeon, can you go in from a different angle and sort of get at it from a different, and they may go back for a re-op to actually get them to gross total resection. For non-metastatic tumors, we just radiate the region of the primary, and that dose varies a little bit, and it depends on who you are, what center you're at. If you're at, anybody here from St. Jude? You can raise your hand. It's okay. I won't say anything too bad about it. No. They radiate to 59.4 because Tom Merchant believes you can radiate to 59.4. If you're at a proton center, nobody does that. And these are the kids that, in the early experience with protons, got some brainstem necrosis when they tried to go to 59.4. The role of chemotherapy is uncertain in this tumor. I will tell you, ependymomas are chemo sensitive. They are probably never chemo curable. And there is this question about whether there are certain subtypes of ependymoma for which you can omit radiation therapy altogether. For the metastatic tumors, we give craniospinal radiation. It doesn't actually work, but it makes us feel better. And we think about chemotherapy in those situations. The prognosis varies a little bit. If you have non-metastatic disease and get a good resection, we do a pretty good job with those patients, maybe even a little bit better than I've listed here. If you're metastatic at presentation, you're not going to do very well. This is a tumor that does like to spread to the spinal cord, and someone should ask me, why don't you radiate? The spinal cord doesn't work. So even though we know, like medullo, this likes to go to the neuraxis, and there might be micrometastatic disease there, it does not appear to be sufficient. You can't kill those cells, seemingly with 36 gray of craniospinal radiation. If you don't get a good resection, we think it's hard to cure these patients. If you recur, you will die of your disease. But we can do a lot to keep kids alive, so often these are focal recurrences that can be reoperated on, they can get chemotherapy, they can get reirradiated, et cetera, et cetera. Okay, so brainstem tumors, and this of course is the worst tumor in all of pediatric cancer, as I've said, and anybody who wants to argue with me, you'll lose. No, because even you solid tumor people who have stage 4 disease, you think you can cure some of those kids, and I don't even pretend to think I can cure any of these kids. So this is an 8-year-old, comes in with some double vision, papilledema, has some slurred speech, and he gets an MRI, which I'll show you examples of in a sec, which shows this tumor centered in the pons, encasing the basilar artery, has some hydrocephalus in this case. A couple things about brainstem tumors. Not every brainstem tumor is the diffuse pontine glioma. Okay, so you've got to be aware of that point, which is that they'll try and fool you on the boards because they'll say, you have a child with a cervicomedullary tumor that's brightly contrast enhancing and exophytic, and that's a pilocytic astrocytoma in the brainstem. You've got to be able to make that distinction, and they will definitely try and fool you, and I believe I try and fool you in my questions that I wrote for this as well. Remember that I've now told you that this tumor, the histology, is now defined if you were to biopsy in two ways. One of which is that it's defined by this H3K27M mutation, and this really reflects what's called the diffuse midline gliomas, which can occur outside of just the pons. In other cases, as I said, if it's not the diffuse pontine lesion, it's probably going to be a low-grade astrocytoma in some other part of the brainstem. So here you go, diffuse pontine gliomas. People will call this brainstem glioma, but you need to be a little bit more specific. Metastatic potential is actually there, but most of these kids don't live long enough to metastasize or to at least have clinically significant metastases. Staging is typically brain only. There is a growing interest in biopsy at diagnosis, and there may be some utility moving forward as we're beginning to learn about some variants and some particular targeted therapeutics. If you do biopsy, this tumor will come out looking like either grade 2, grade 3, or grade 4. So it's a diffuse astrocytoma. It might look like a diffuse astrocytoma grade 2 or anaplastic astrocytoma grade 3 or GBM grade 4. They all die. They all do badly. Having a 2 doesn't mean your outcome is going to be better. And someone will write a board question about that as well, that you biopsied this kid and it was grade 2. What should you go tell the family? Don't tell them that you should feel good about the fact that it's a grade 2. They will still die. The genetics, about 80% of these patients have this histone H.31 or H3.3 mutation. Here is sort of classic imaging of a patient with a diffuse pontine glioma. So you can see this engorgement of the pons on this T2 or FLAIR imaging here. You can see that the basilar artery is I can do this without advancing here, and sort of engulfs. It doesn't obstruct the basilar artery, it just kind of sort of forms its way around it, so you don't have vascular compromise. This is a whole mount of someone who has obviously died of their disease, and this is the pons, and it's just a necrotic mess, and it's a really, really devastating diagnosis. The only therapy that we tend to offer routinely is palliative radiation therapy. It does not cure anybody. It probably slows down the time to progression, and there typically will be some honeymoon period after radiation. That period of time will be about 3 to 12 months. There has to date been no chemotherapy of any sort that has ever altered the natural history of this disease beyond what is provided by radiation therapy alone. So we've tried it all: neoadjuvant therapy, chemoradiotherapy, bone marrow transplants, therapy at the time of progression. Everybody dies in about the same amount of time, and you can almost use your response to radiation as sort of your predictor. If you have a really nice response to radiation by imaging and by clinical improvement, you'll probably have a little longer honeymoon period, but you will die, sometime typically at about a year to 2 years. There are some late survivors. We don't know who those patients are. Historically, none of those kids were biopsied, so we don't actually know if we fixed a kid who actually had a diffuse pontine glioma or we radiated something that looked like a diffuse pontine glioma and they survived. For my own sanity, I like to think that we actually fixed a few kids, but I actually think that's probably not the case. I mean, as I said, almost everybody dies between 6 months and 2 years. These are the pointers, and I have these for most of the different areas. There is a difference, as I said, between an intrinsic pontine glioma and an exophytic brainstem tumors. Exophytic brainstem tumors is code for pilocytic astrocytomas. Most of those tumors will be brightly contrast enhancing in contrast to what you see in the pons, which typically doesn't take up much contrast. Pilocytic astrocytoma is the most common brain tumor seen in children. Here's a typical example of a kid who had bifrontal headaches, and you can sort of imagine this litany of events that occurred before they finally were diagnosed because they started to have a little lack of coordination of their left hand. Nobody did anything wrong in this kind of a case. It's just these are slow-growing tumors, and it takes time before they present in a way that's evident. They can occur anywhere in the brain. The common locations are the cerebellum, the optic pathway, and again, you'll hear optic pathway glioma, in the hypothalamus, in the brainstem, in the spinal cord. So everywhere in the brain is pretty much up for grabs. There's a lot of different ways this tumor is described, but just call it a pilocytic astrocytoma. Obviously, how it presents is location dependent. It largely doesn't have metastatic potential, and generally speaking, I don't think you have to stage beyond the imaging of the primary site. There are no specific laboratory features, meaning histologic features above and beyond kind of it is a pilocytic astrocytoma. What we do know is that these tumors commonly have a BRAF truncated fusion, or in a subset, they'll have BRAF V600E mutation, and this is becoming relevant as our therapeutic targets have evolved. Here is really a textbook example of a cerebellar astrocytoma, which is a pilocytic astrocytoma in the cerebellum. You see this brightly enhancing mural nodule with an associated cyst. The surgeon will come in, decompress the cyst, pull off the tumor from the wall of the cerebellum, and you're pretty much good to go. This, as I pointed out before, was also a pilocytic astrocytoma of the optic nerve. The problem for this kid is he looks a little reptilian, and that's not so great in terms of, you're kind of, walking around and stuff. And so the question becomes, even if there is retained vision, how do you manage that? Because kids don't really want to eventually walk around with one eye sort of jutting way out. In the meantime, it's nicer to have binocular vision, and so we try and do other things, typically chemotherapy related, sometimes for cosmetic reasons. This, unfortunately, is also a pilocytic astrocytoma, so this is a hypothalamic region tumor or thalamic region tumor. These kids have big problems. They all have 5-year survival rates, which are fine, but I don't know that they all have normal lifetime survival rates. These are tough tumors. They have a lot of symptoms from these. They often need shunts. They often have repeat, sort of partial surgeries. They're somewhat chemo-responsive, somewhat radiation-responsive, but they're a tough group, and they often require many lines of therapy before we sort of get the tumor under control. How we treat this tumor depends on location. So gross total resection is curative. What you can generally cut out fully are the cerebellar primaries and occasionally some of the lateral supratentorial primaries. If you can cut it all out and think about basically anything that's in the midline as being difficult to do that, what we do very much depends on who you are and kind of what symptoms you're having. So in some cases, they're incidental findings. We have lots and lots of kids that we see who got imaged for some other, we're in the car accident and someone got a scan and lo and behold, they have a small lesion. They were pretty convinced it's a pilocytic astrocytoma. We just watch it. We try best safe resection if it makes any sense to do that. Sometimes just biopsy, and then we give a lot of different chemotherapies. And I will say today that there is a growing sense that radiation therapy should really be reserved for. We have tried every possible other strategy before going to radiation therapy. There are a lot of different regimens that we utilize. Carbovincristine is probably the most common. TPCV is probably similarly utilized. You can give carbo alone, you can give vinblastine, you can give other slightly more regimens like cisplatin etoposide, which have more long-term toxicity risks. We are beginning to think about the targeted therapies for some patients, at least in the recurrence progressive setting. For the BRAF fusion, remember MEK inhibitors are perfectly fine. If you have a V600E mutation, the BRAF inhibitors are fine. Never, ever, ever use a BRAF inhibitor for someone who has a BRAF fusion, because that will cause paradoxical activation and you will basically fertilize the tumor and watch it grow. So the prognosis is generally very good. The midline tumors have a bit more variable prognosis, as I've mentioned, because gross total resection is difficult. I'm running out of time. I'm going to have to talk really fast now, so hold on to your hats. So optic pathway gliomas, again, is just another name for pilocytic astrocytomas occurring in the optic pathway, the nerves, the chiasm, or the radiation. These occur often in younger children. There's a high incidence of this tumor in children with NF1. What we do depends. In the NF population, in many cases, we can just watch those patients. Chemotherapy can be given in just the way you would for other pilocytic astrocytomas. Can occur anywhere in the brain. If you cut it out, it's curative. Remember the association of optic pathway pilocytics and NF1. For the high-grade astrocytomas, this is a patient who presented with seizures, nausea, vomiting, and headache. These are the grade 3 and grade 4 WHO tumors, so these are diffuse astrocytomas. Again, how they present varies, but seizures are not uncommon in this population because of their predilection for the supratentorial compartment. They only represent about 4 to 5% of the tumors seen in children. They don't have much metastatic potential, at least at presentation. We do typically stage the brain and sometimes the spine. There's some things that we're looking at in terms of things that may predict responsiveness to chemotherapeutics, like MGMT promoter methylation. This is the little listing, and I've more or less talked about this already, about the different genetic variants that can be seen among some of the astrocytic tumors, so I have it there for your reference. Again, as a reminder, if you have a V600E mutation, you can use a BRAF inhibitor. If you have a BRAF fusion, you cannot use a BRAF inhibitor, and you have to think about these studies using MEK inhibitors now. Here's some examples of patients with a high-grade astrocytoma. So you see this post-contrast, highly serpiginously contrast-enhancing mass with a necrotic center. This is the same patient at the same time, and this is T2 imaging on the other side here. And everywhere you see bright signal, ignoring the ventricle because CSF can be bright, there's tumor in that location. So that's why there's really no gross total resection for high-grade infiltrating tumors. So maximal surgical resection, focal radiation therapy. Most people give low-dose temozolomide during radiation therapy. The data for that is modest, and I should know it because I did the study for COG, but nevertheless, I think it is fairly commonly utilized. The role of adjuvant chemotherapy is quite debatable, but I would say most people tend to do something else because radiation therapy or radiation therapy with chemoradiotherapy Temodar is not sufficient therapy for most patients. You do have some chance of curing some kids with anaplastic astrocytoma. Remember, this is a spectrum disease, so you can be just over the line of a grade 2 and maybe get a good resection, and that may be the group that gets cured. We cure very, very few kids with frank glioblastoma. Really, no chemotherapy, with the exception of alkylating agents, have really shown much benefit in the treatment of these tumors. Whether temozolomide is necessary, hard to say, but I think it is fairly standard these days. And again, what you call one of these tumors and sort of where it falls on the spectrum is really very much still in the eyes of the pathologist. For the germ cell tumors, this is a 19-year-old who came to our attention after bumping into objects, being dizzy for 3 months, and I asked him why he thought it was okay to do that for 3 months, and he didn't really have a good answer, which was disturbing. He came in and he presented with diabetes insipidus, which is the most common endocrine abnormality in patients with CNS germ cell tumors. So remember, germinoma, this is the non-secreting germ cell tumors. There are 2 common locations where this tumor occurs: the suprasellar region, where you would see diabetes insipidus as the most common presenting symptom, poorly spelled, hypopituitarism. And in the pineal region, as I've talked about before, just like pineoblastoma, you can have Paranode syndrome and raised intracranial pressure. You do need a biopsy for diagnosis of germinoma. So this is another one of those like horrible trick questions that you're going to see about, you send tumor markers and they were negative and they're trying to steer you away from the idea of a germ cell tumor. Remember, germinoma does not typically have sufficiently elevated markers. They can sometimes have a little bit of beta-HCG elevation for you to make a diagnosis without doing a biopsy. We do stage the neuraxis, including the spine, and do CSF cytopathology. So the CSF markers are basically negative, or you can actually have a slight, as I said, low level of beta-HCG and still be classified as germinoma. Here is a patient who has tumor in both the suprasellar and the pineal region. About 10% of germ cell tumor patients will present with multifocal disease, and those are the 2 most common locations. You have 2 ways you can treat these patients. You can give them neoadjuvant chemotherapy and see how well their tumor shrinks down. And that therapy is typically carboetopicide. If you get a good response, you get a little reduction in your total radiation dose. One of the things that's very important is you must radiate the whole ventricle, so that it turns out that if you don't, those kids will all fail in the ventricle. You can also give them radiation therapy alone at a slightly higher dose in the event that you would otherwise not have had a good response to the upfront chemotherapy. Which one is better will never be known. There was an attempt to do the study in COG, and it never enrolled because there was so much institutional bias about which way they like to treat these patients that the study closed after like 3 kids enrolled. So we don't know the answer. I would say today, particularly the younger you are, the more effort there is to probably give the neoadjuvant chemotherapy. Prognosis is excellent for these patients, whether you get radiation therapy alone or combination therapy. If you develop an endocrine abnormality, if you have DI from your germ cell tumor, you will always have DI. So fixing your tumor does not fix your endocrine abnormalities. For the non-germinal germ cell tumor, and this was a kid in the interest of time who came in, he looked like, on The Wizard of Oz, like the lollipop kid, really muscular and a deep voice and a little mustache, and his genitalia were somewhat larger than his father's, I think, and yet the mother didn't recognize that as problematic until he started having body odor, and then she thought that was odd. Any event, so this is a kid who presented with precocious puberty from a secreting germ cell tumor. These kids can have a diagnosis made by markers. Do not let your neurosurgeon take a kid with a suprasellar mass or a pineal region mass who can get sampling done, minimally of serum, preferably of CSF, to the operating room, because if you know that it's a non-germinative germ cell tumor, you can save that kid a craniotomy and make the diagnosis and still effectively treat them. The markers will typically be elevated. Which one depends on which particular variant, just like in the systemic germ cell tumors. Here's a very benign-looking thing, but that's one of those tumors. In fact, that was this kid's tumor, who is now 29, and he's grown into his penis, and it's been a very happy ending for everybody. The therapy is typically neoadjuvant chemotherapy. It's pretty aggressive, actually. And then once you get done with that, you get response-based radiation therapy. It does include typically craniospinal radiation, although there's been some looks at whether you could get away with less. There is some talk about second-look surgery after the neoadjuvant therapy. When this is typically done is in situations where the markers have normalized, and yet the mass looks bigger, and sometimes there's some question like what's going on there. That might be growing teratoma syndrome. But if a kid has growing mass and growing markers, they have failed therapy, and then they need some other sort of a salvage. Prognosis is actually pretty good. So in the last big COG study with aggressive modern therapy, about 80+% of the kids had event-free survival. And in that study, there was a plan to use transplant. I think nobody actually went to transplant. Here's a few important pointers that I've sort of gone over already. CSF markers are not elevated in germinoma, especially AFP. You cannot have any elevation in AFP and call that germinoma. A cult DI in a teenager is germinoma waiting to declare, or LCH, Carl. Non-germinal germ cell tumors require more intensive therapy, and remember, about 10% of germinomas are multifocal. Spinal cord tumors, quickly, a bunch of tumors can find their way to the spinal cord, but there are a few tumors that like to present just in the spinal cord. So low-grade astrocytomas, often pilocytic astrocytomas. Ependymomas, as again I talked about, often the myxopapillary variant. And you can get high-grade astrocytomas in the cord. They're not very common, thankfully, because they're particularly miserable diagnoses. The symptoms make some sense: back pain, upper or lower extremity, change in bowel or bladder function, those sorts of things. There are tumors that like to go to the spinal cord, so all the embryonal tumors have that interest. So medulloblastoma, CNS, I used to be PNET, pineoblastoma, germ cell tumors, ependymoma. Astrocytomas can do it. They don't do it quite as commonly. What about stem cell transplantation? I think the story these days is that it really has a fairly limited role. Is anybody here at Nationwide? Oh, it's like a whole group back there. Do not tell Jonathan I'm about to say this. So I think that the deal is that stem cell transplantation was used as a strategy, particularly for the very young children, in an effort to avoid radiation therapy. It probably has some role or can be utilized as a different strategy for some of the embryonal tumors to try and delay or avoid radiation therapy altogether. It really has an unclear benefit in the astrocytic tumors, and I would say today there is very little evidence that particularly autologous transplant in that setting has any utility. Although some would argue. Whether it can be used for salvage, I think, is debatable, but less and less enthusiasm with more modern upfront therapy. There are a few genetic associations. I've already alluded to a couple of these. NF1, you must think about optic pathway gliomas, which again are usually pilocytic astrocytomas. They also get these non-neoplastic hamartomatous lesions throughout the brain. They often have a very benign course and don't require therapy. Remember for tuberous sclerosis that there is a specific tumor, the subependymal giant cell astrocytoma, typically presents at the foramen of Monroe, can cause obstruction. Used to be a surgically managed disease. Turns out that you can use mTOR inhibitors, and there's very nice data and approved indications for this patient population. ATRT, just to sort of say, as everybody know, it has gone by a lot of different sort of genetic names in terms of what you're looking for. It used to be thought of as uniformly fatal. It is not. The therapy is more sarcoma-like than most other therapies that we give in brain tumors. It is very important that your pathologist is thinking about this diagnosis because it has fooled people in all sorts of different diagnoses. So there's been ependymomas that have been called ATRT, or ATRTs have been called ependymoma, ATRTs that have been called choroid plexus tumors, ATRTs that have been called medulo. And so you've got to have a high index of suspicion. We do recommend genetic testing for every child who in fact has this diagnosis to confirm whether it is germline versus sporadic. And then I think the last slide is the genetic association, which Carlos alluded to before, which is in retinoblastoma for trilateral disease. Trilateral disease is basically pineoblastoma presenting in those patients, and that's just something you have to be aware of. And this is something that means in those kids with retinoblastoma, you have to do some monitoring of their brain for some period of time. And I'm sorry I ran a little bit over. Oh, sorry, shit. Ooh. Take that last word out of the thing when you give it to everybody and they pay for it. They shouldn't hear me swear. Complications and late effects, obviously what you have from surgery depends on what they cut out, burn, suction. A big issue is cerebellar mutism syndrome, posterior fossa syndrome. It's a big deal and we have to think hard about that in our patients. Radiation therapy, everybody knows, neurodevelopmental injury, endocrine injury. You are at risk, significant risk actually, not tons, but enough of secondary tumors, including GBMs and commonly meningiomas. Chemotherapy everybody knows about, particularly hearing loss from the platinum-based therapy, second malignancy. Endocrine, as I mentioned, what you've lost, you lose, and you never recover that again. And then this is the first page of the content outline, and that's the end of the show. I'm guessing we don't really have time for questions since I just told you 1,000 things in 27 minutes. But if anybody has questions, just come up and find me.